Good evening, everyone. This is Ashkan Lashkari, MOASC President and Community Medical Oncologist in Southern California. Tonight, I'm really pleased to present a webinar that I'll be moderating with our expert panelists. Uh, and tonight's webinar will be addressing challenging cases in breast cancer, particularly the metastatic breast cancer setting. I am very honored to share this platform with our expert panelist, Dr. Rebecca Shatsky from UC San Diego, who heads their breast oncology program, and her counterpart at UCLA, Dr. Aditya Bardia. Thank you so much for joining us, everyone.
Thanks
Thank
for
you.
having us.
Yeah, absolutely. So, next slide. So I'm just going to go through tonight's agenda. Christy, can we do the next slide? Yeah, thank you. So tonight's agenda will be looking at how we integrate molecular testing in the metastatic setting. And this will look across the different subtypes of breast cancer, as well as review updates in the management of metastatic breast cancer in the HR positive, HER2 negative setting, HER2 positive, and triple negative setting. There's a lot that's been going on in the last year and more to come with ASCO 2025 on the horizon. And then finally, we'll discuss some highlights in the management of brain metastases, particularly involving systemic treatment options in the HER2 positive setting. All right, next slide. All right, so I want to make this very conversational. So I'm just going to start with this and then going to ask you guys to, Dr. Bardia and Dr. Shatsky, to kind of comment. So this is a 44-year-old female who I saw a few years back. She presented with bone-only metastases, left-sided breast cancer. She had a palpable mass. Um, they were both biopsied and consistent with HER2 positive or hormone receptor positive, HER2 negative breast cancer. It was 2 plus positive by IHC, FISH negative. Germline genetic testing done was done and negative for any mutations. And I did tissue NGS at the time. She was found to have a PIK3CA mutation. She was also found to have a PTEN, P10 positive with a frame shift, along with an FGFR2 being a missense mutation, or TMB was slightly elevated at 13 uh, mutations per megabase, and PDL1 was negative. A liquid biopsy was also done and showed those mutations that you see there. So I'm just going to ask you, Dr. Shatsky, is this, um, in terms of a young woman presenting to you, how would you go about, working the patient up and getting her set up for treatment?
Yeah, so it sounds like a young woman, unfortunately, with what I would consider luminal B disease. So a little bit more on the aggressive spectrum, a little bit higher tumor mutational burden. As far as the molecular profile, too, the PTEN loss, it's almost always a loss there. It's not a good prognostic factor. Like that's one of the things we know about PTEN is that it signifies aggressive disease and can be a bit more resistant. The PI3 kinase gain of function mutation is a nice target. As you know, I'm actually going after FGFR mutations a little bit these days too. Um, you know, all of that being said, with her bone-only disease and everything, I would still go to a aromatase inhibitor and CDK4/6 inhibitor as my first line option. I tend to use ribociclib at this time. The overall survival data for that drug definitely sways me, and so I don't use much palbociclib, especially in a young person like this. And given the lack of ESR1 mutation, that would be quite rare for someone who's de novo, but it does happen in about, 0.5 or 1% of patients. Um, but yeah, I think that I would start her on a CDK4/6 inhibitor, a letrozole, ovarian suppression, of course, and encourage her to think about having her ovaries removed because that certainly simplifies things for the patient. It can lower costs overall because there's not going to be a time when she's going to be off of ovarian suppression. And some of those GnRH agonist copays can be quite high. And then also start her on a bone strengthening agent, either zoledronic acid or denosumab.
And in terms of the the germline, or I should say the genetic testing done through tissue NGS and liquid biopsy, Dr. Bardia, would you typically perform both, one um, at this time at the time of diagnosis, initial diagnosis?
Yeah, I usually do get tissue testing done because we are looking at ER/PR HER2. And so if you have the tissue that's needed for confirmation of diagnosis receptors, often you can send that for sequencing. The liquid biopsy does not change what I would do at this time. So like for this patient with de novo metastatic disease, likely we'll get endocrine therapy plus a CDK4/6 inhibitor, as Dr. Shatsky said. So the liquid biopsy would not change what I would do, but that is something that could be helpful in the future.
Okay. Um, and so we can go to the next slide. I just included here the NCCN uh, options available for this patient. And of course, you're right. At this point, aromatase inhibitor plus ribo would be considered, category one, with the other options being other CDK4/6 inhibitors, equally being, I guess, an option. But I mean, should we all be transitioning to ribo based on the overall survival data? Is there is you know are we less effective potentially? I know that some physicians have more comfort using one of the CDK4/6 inhibitors over the others. Do you think you think that's still a reasonable reason to select a particular drug, or if, let's say, patients have a preference and based on the toxicity of the CDK4/6?
Yeah, I can start. I think if someone is already on palbociclib, I would continue that. I would not make a switch. But if you're starting afresh in general, we would lean towards ribociclib given the overall survival advantage, with the understanding that you start ribociclib, and if you run into issues, LFTs or something else, then you can switch to the other CDK4/6 inhibitors. And at the end of the day, it's a patient-centered discussion. If there's someone who's really concerned about ribociclib side effects, who prefers palbociclib for some reason or abemaciclib for some reason, you could certainly consider that.
Most of us in the breast onc community are have switched to ribociclib and we don't do new starts with palbociclib unless there's a specific reason. So I'd say we tend to favor palbociclib like in the above 80 population, the elderly. We're really worried about tolerance, or if there is significant issues with ongoing heart disease and you're worried about QTC prolongation. One thing you do need to know about in ribo is that it can cause this sort of immune responsive transaminitis. And so in young, healthy patients, like a de novo patient, that's something that you do need to keep an eye on, the liver function abnormalities.
Okay. All right, we can move on to the next slide. So I wanted to bring up the kind of newest PIK3CA inhibitor, this inavolisib, which was approved in conjunction with palbo and fulvestrant, but has a particularly unique indication, right? It's not used necessarily um, in de novo patients, if I'm not mistaken, right? This would be something that might be considered for somebody if they were in visceral crisis following progression on adjuvant endocrine therapy, or once they've already completed endocrine therapy.
Yeah, that's exactly correct. And we often talk about, dependency of the tumor. So in general, tumors that are ER dependent, we would use endocrine therapy plus a CDK4/6 inhibitor, like the patient you mentioned, which has de novo disease. But if a patient has been on adjuvant endocrine therapy and then has disease recurrence on adjuvant endocrine therapy, that patient likely has endocrine resistant disease. And in that setting, the PI3 kinase pathway is more active. There were studies done 10, 15 years ago where they looked at PIK3CA mutation in the adjuvant setting, and that does not necessarily confer for resistance to adjuvant endocrine therapy. So just because PI3 kinase mutation is there doesn't mean the tumor is dependent on the PI3 kinase pathway. But in the endocrine resistant setting, it's almost like that PI3 kinase gate opens up and the tumor becomes more dependent on the PI3 kinase pathway. So in an endocrine resistant setting, I feel very comfortable with using PI3 kinase inhibitor. But just because there's a mutation in a de novo setting, it's not that we should be using a PI3 kinase inhibitor.
Correct.
It's a subtle point, but I wanted to emphasize this.
And it's important to think about the toxicity here too. This is not an easy drug to tolerate by any means. And so de novo metastatic patients tend to be quite sensitive to therapy because they don't have that resistance that has developed in response to the endocrine therapy that they were on before. So I would not be using this as a first-line agent. What we know about these PI3 kinase mutations is that patients still can do great on their CDK4/6 inhibitor. You do not need to go after the PI3 kinase mutation first, just because it's there. You can, sequentially treat, going with your CDK4/6 inhibitor first, and then your PI3 kinase pathway inhibitor. I say pathway because a lot of the time we're using capivasertib, which is an AKT inhibitor, a little bit downstream. And the goal here, of course, is to make the patient live as long as possible. And so there is something to be said for using up all of your therapies early when you might not need to.
Yeah, it's an interesting drug. I certainly haven't had an experience using it, but these PIK3CA inhibitors definitely seem to have a little bit more toxicity compared to
Yeah.
Cavi. I wanted to, so going on to the next slide, I wanted to just, just kind of round out this case. So this patient was treated with ribo-letrozole plus ovarian suppression and incidentally did get zoledronic acid. She had a reasonable response for about 2 years, progressed with further disease in the bone and in the left breast. At that point, I did perform a liquid biopsy. And, interestingly, we didn't find an ESR1 mutation. She had a very similar mutation profile otherwise. Um, in what percentage do we find ESR1 mutations following progression or upon progression?
It partly depends on how often you check. So in general, I would say 25-30% of patients would have detectable ESR1 mutation after first-line therapy. But then with repeat testing, you can see ESR1 mutations which were not there initially. And some studies have described up to 50% of patients with ER-positive MBC could have ESR1 mutations. So I think the key is to do serial testing.
Yeah, I was going to say the same thing, that there's a lot of different studies with a little bit different results on this. So we kind of quote somewhere between 20 and 50%.
So it's depend, and also I guess it's dependent on how you test for it or how often, right? And I guess if patients don't have significant circulating tumor DNA, you might miss it, or especially if it's at a smaller frequency. Um, do you tend to see it more in the secondary metastases versus the primary? I suppose that would make more sense.
Yep, yep. And the initial studies that looked at ESR1 mutations in primary breast cancer just did not see ESR1 mutations because it's an acquired alteration.
The de novo ones can exist, but they're extremely rare. It's like 0.5% ever in a primary tumor.
So, this patient actually was treated with alpelisib. mainly because Cavi, so this patient was treated a little while ago. So this was before Cavi was approved, and so she was placed on alpelisib plus um, uh, fulvestrant, and actually did quite well. She had quite a bit of toxicity with the alpelisib, with with mainly hyperglycemia, for which she effectively became diabetic. She was on two oral hyperglycemics, nearly needed to start, insulin, but she did have an excellent response. And, my question is, Dr. Shatsky, how is there any way to predict, what patients might have a more durable response with these PIK3CA inhibitors, or even with Cavi, with if you were to use that drug, is there any kind of biomarkers that might drive whether someone might do better or not from a prognostic standpoint?
Well, we do know that the most common hotspot mutations were really the majority of patients tested in these trials for alpelisib and capivasertib. Um, but it's difficult to say which ones are going to do really well or not. I don't use alpelisib anymore because the toxicity is so bad. I've had patients need to be in the hospital on an insulin drip because of that drug. You also, I mean, as a class effect, this entire pathway is going to have some hyperglycemia, edema, rash, and diarrhea. And all of those can be fairly severe. And so capivasertib, it is more tolerable in my experience. It can cause the hyperglycemia, but at a lower level. It can cause rash, but not the kind of tomato, really horrendous rash that alpelisib causes. And there's a very severe colitis that can develop with alpelisib too. I get diarrhea with capivasertib, but not to the extent that I've had with alpelisib, where I have to hospitalize the patient for grade 3 to 4 diarrhea.
Yeah, these can be difficult. If, let's say, this patient had an ESR1 mutation along with the PIK3CA mutation, which we know tends to be uh, a mutation that can be found at time of diagnosis early on. How would you treat the patient at that point, Dr. Bardia? Would you put them on a SERD first, like olacestrant, or would you start them on one of these other options, such as
Yeah,
alpelisib or capi?
it's a good question and something we do see in clinical practice because you can have coexistence of ESR1 and PIK3CA. These are different pathways. Um, you don't have head-to-head comparison between elacestrant and say fulvestrant capi or fulvestrant alpelisib. So we have to go by subgroup analyses. From the Emerald trial, we do know that patients who had both ESR1 and PIK3CA or who had ESR1 and PTEN mutations, as long as the prior duration of CDK4/6 inhibitor was more than 12 months, they did derive benefit. The median PFS, depending on the subgroup, was 6 months or 8 months. So it does provide decent benefit. The advantage of single agent elacestrant is that it's better tolerated than combination therapy. We were talking about side effects with PI3 kinase agents. So that's one advantage of using single agent therapy. And if a patient does well, great. If they have disease progression, we will be using the combination as the next step after disease progression.
Yeah,
Okay.
I tend to sequence in a double mutant if they have an ESR1 mutation and a PI3 kinase, as long as they don't have a completely unstable genome where I'm seeing like 10 to 15 copy number alterations and like 18 ESR1 mutations, because those are just overall a bad prognostic sign and less likely to respond. Then I'll use the elacestrant first with close monitoring, and then move to my PI3 kinase targeting pathway drug after that on progression.
Well, that's very helpful. I mean, I mean, that's very helpful because I think, with all these options now available, how to sequence is something that um, I think we're all gonna, struggle with until, there's more data, or at least we have a little bit more, real world information.
Yeah, the subgroup analysis of the Emerald trial, obviously that's Aditya's trial, so he really knows this data better than anyone. But the subgroup analysis showing that double mutants did benefit from elacestrant just as much as a non ESR1 mutated patient, or sorry, a PI3 kinase mutated patient. Sorry, I misspoke there. That was compelling to me because it meant that I could sequence my drugs and reserve the PI3 kinase or AKT inhibitor for after if I needed to.
Okay. Well, this case more or less ends. I'm just gonna go to the next slide, and that is the looking at systemic therapy from a chemotherapy standpoint following endocrine treatment. I know there have been some updates now with the preferred chemotherapy option. This particular patient did ultimately um, progress on alpelisib and uh, fulvestrant, and I transitioned her to capecitabine. Um, but now, if with the current data that we have now, I don't know if that would be the best choice, because now we know that T-DXd is very effective in these patients. Is that how you would, treat your patients now who are transitioning from endocrine therapy to chemotherapy?
You want to take that first?
Yeah, I might be biased because involved with the study. I think it's an option. So we know from Destiny Breast 06 that T-DXd was superior to capecitabine, but it's also given IV, does have side effects, and majority of patients in Destiny Breast 06 had did not have bone-only disease. So if you have a patient who has bone-only disease, I think it's a discussion.
Yeah, so I know that Aditya and I feel kind of similar on this. We share some patients. And for bone-only disease, what we really want to do is maximize the time on oral, less toxic therapies as possible because Enhertu is rough. It is really not an easy drug to tolerate. It causes pretty severe nausea. It causes really bad fatigue, and it has the risk of ILD. And so we do reach for this in our really aggressive disease, like liver mets are progressing, kind of, unstable genome patients on the earlier side. But for a patient with bone only disease, I feel very strongly about maximizing the time that I can, where I don't commit a patient to the infusion center on a regular basis, give them horrible nausea, a risk of dying from therapy from ILD, and hair loss. I try to preserve their hair as long as possible because that's really important to my patient population. So I'm not going to go with therapies that like you have hair, you don't have hair. You have hair because that's a really big quality of life thing for these young women.
Yeah. And now that we have these other ADCs that such as sacituzumab govitecan and now datopotamab, um, what's the kind of thought there in terms of sequencing? Would you give a break from one ADC if you were to consider switching to another ADC, either if upon progression or intolerance of the initial one?
That's another good
Dr.
question.
Bardia?
We now have some data. Laura Huppert looked at multicenter experience of ADC after ADC, which is now published. And in their series, they did not see any difference if you do the sandwich technique of ADC, then chemo, then ADC versus just ADC after ADC. And we know that with every line of therapy, there's a proportion of patients who don't get to the next line. So my personal feeling has been to use our best agents as early as possible. And when I use the second ADC, I tend to get scans earlier because there could be a subset of patients who have cross resistance. So rather than wait for 4 or 5 months, usually more closer to the 2 month mark, maximum 3 month mark, I get repeat scans just to ensure that the second ADC is working.
Yeah, I just posted in the chat the paper that Aditya is referencing. It was Laura Huppert, who's at UCSF, a good friend of ours, and Hope Rugo, of course, a senior author. And the data for sequencing ADCs is hard, meaning that if you respond really well to ADC number one, it is less likely that you're going to respond to ADC number two after that. And it doesn't seem to matter if you sandwich, say, eribulin in the middle or something like that. What we're seeing more and more as far as the mechanism of action for ADC resistance is that it's not necessarily the target, it is actually becoming resistant to the payload more so. And so we've tracked the clonal evolution of these resistance clones, and what we're really starting to need is different payloads, and the majority of our ADCs are topoisomerase 1 inhibitors. So sometimes we get a benefit from both, but the likelihood of response for the second one is certainly significantly decreased.
Yeah, I think again, it's all these different options and their side effects. We're gonna see some unique experiences that we're all gonna have in terms of what our patients are gonna be going through. And yeah, I mean, it's nice to have all these treatments, but you just hope that there are no the side effects aren't cumulative in terms of increasing the risk of whether it's ILD or cytopenias or so forth. But I think it's exciting that we have them, but it'll be interesting. I certainly, I'm going to look at this paper that you presented here because I think that's very helpful for us. We can go on to the next case. This is a HER2 positive metastatic breast cancer case. So this is a 64-year-old female. She presented with a 4 centimeter left breast mass with palpable axillary adenopathy. Again, both the breast and axillary lymph node were biopsied, consistent with ERPR negative, HER2 positive by IHC and FISH. PET CT MRI were done, and patient was found to have metastases to the liver and intrathoracic lymph nodes. Tissue and liquid biopsy were done, found to have increased ERBB2 copy numbered, along with mutations in TP53, PMS2, and DNMT3A. She was microsatellite stable. Germline genetic testing was negative. So we can go to the next slide. This patient was treated with what is considered now, standard of care frontline treatment, pertuzumab, trastuzumab, docetaxel. She did well, but progressed within the liver 18 months later. Do you think that we'll see a replacement to this option? I know that the T-DXd Destiny 009 trial is looking at that with T-DXd in the frontline setting. Any comments on that?
Yeah, so Destiny Breast 09 was positive. They've had a press announcement, meaning that that was first line in HER2 versus the Cleopatra trial THP for metastatic HER2 positive disease. The controversy, I would say, about that trial is when you do THP per Cleopatra trial, you sort of give, on average, say 6 cycles of the chemotherapy portion, the Taxotere portion. And then you can drop that and maintain the patient on pertuzumab, trastuzumab alone until progression. When you're doing in HER2 first line per Destiny Breast 09, they're on in HER2 indefinitely until progression, which is quite toxic. And we do see with in HER2 that the longer you're on the drug, the more likely you are to develop ILD. It can happen year 2, year 3. And so there is another trial that's coming out that's looking at a more similar approach to Cleopatra, meaning induction within HER2 for, say, 6 cycles and then maintenance. And I think a lot of us, I'm a little bit more interested in that approach than I am in committing the patient to several years of Enhertu, because another toxicity that I didn't mention before about Enhertu that we're seeing in clinical practice is that we're seeing damage to the liver in a similar focal nodular hyperplasia pattern that can lead to portal hypertension with long-term use, just like we saw with TDM1. And so I've had several patients develop that. They get a cirrhosis-like picture, and that can be quite complicated. And so while Destiny Breast 09 is positive, I don't know that I am ready to make that switch as of the presentation at ASCO coming up.
Yeah. Dr. Bardia, any comments or thoughts similar?
Yeah, no, 1st of June. So the results were presented on 1st of June, 7:30 in the morning.
Are
It's
you giving it?
no,
Oh,
it's Sarah Toledo.
okay.
It's out in the public domain now. So it's very similar to last year where we had a special session for Destiny Breast 06. There'll be a special session for another Destiny trial. And it'll be good to see the results. And exactly as Becky was saying, in terms of should we continue T-DXd for a long period of time or use it for a few cycles and then switch to pertuzumab and trastuzumab, which is very well tolerated from a patient perspective. And then maybe add the CDK4/6 inhibitor as well, based on the patina study for patients with ER positive, HER2 positive disease.
Exactly. I'm much more interested in that approach, which is much more tolerable from a patient perspective than just kind of continuing in HER2 indefinitely. Do you remember the name of that switch therapy trial? I'm forgetting it for some reason.
I know it's by the MedSer group, but I don't remember the name.
Yeah, let me try and find it. It has a funny name.
So
Oh, is the
I'll just,
Mirador? Is that the Mirador study?
Let me look it up.
Yeah, we'll look it up.
well, I wanted to ask you, with these patients with HER2 positive disease, and I miswrote here on this slide. She progressed ultimately in the liver, had a repeat biopsy, and it was uh, HER2 positive, hormone receptor negative, similar. Um, and she was somewhat insistent on having the biopsy. Um, and I wanted to also, repeat, NGS testing. My question though is that necessary in the HER2 positive setting? Are we, I know that sometimes we can see some changes in HER2 status, but are you finding actionable mutations in the HER2 setting that might guide therapy in subsequent lines?
Generally not. Once you have HER2 amplification, generally it stays. Here and there, you can have a tumor that loses HER2 gene amplification, but even then, and HER2 works in that setting. So it's less relevant these days, especially with T-DXd. In terms of actionable alterations, if I see PI3 kinase or AKT, it would not change what I do unless there's a clinical trial. If I have a PI3 kinase inhibitor clinical trial that allows patients with HER2 positive disease, then it might be helpful. But generally, as compared to ER positive disease, where serial testing can be very helpful because you'll pick up actionable alterations, it's less so in the HER2 positive setting.
Okay,
Agreed. There's really not a lot of, I mean, these HER2 patients are really driven by that genomic marker. And the only other thing that we see pop up in them really is, and it's usually there from the start, is a PI3 kinase mutation. It can be a resistance pathway that develops as the tumor utilizes, upregulates the PI3 kinase pathway, but we don't have approval for use of those agents, even though they are in clinical trials right now. So the only thing that it becomes kind of relevant, and probably we'll see drugs for this in the future, is those sort of PI3 kinase pathway mutations sometimes.
So this patient ultimately progressed in the brain, and she had relatively small multifocal disease in about three different areas, not large, not symptomatic. And so um, she met with radiation oncology, but we decided to forego radiation therapy and transition her to systemic therapy. And she received treatment with tucatinib, capecitabine, trastuzumab, um, and wanted to kind of get your thoughts because I know that both in the HER2 CLIMB trial and now in the Destiny Breast 12 trial, both have shown significant activity within the brain. Maybe we can go to the next slide. In the HER2 Climb trial, there were significant response rates within the brain and quite durable, as you can see here. Are you approaching your patients the same way and really resorting to radiation much less, particularly if patients are not symptomatic? Dr. Shatsky?
So, not necessarily. I'm more concerned with using up my lines of therapy. So if it's a single met to the brain, I will usually approach this as do SRS to the single brain met and then keep them on the same therapy and then repeat a brain MRI around 8 weeks after. And if they have progression and more mets, then I will switch. But if I can get more time out of the systemic therapy option, then I kind of prefer that because again, I'm most worried about using up. We have sort of a limited line of therapies in HER2 positive disease, even though patients last forever on them, which is fantastic. It's not indefinite therapy. So if it's a single metastasis or maybe even like up to 3 that are amenable to SRS, I will sort of have my neurorad oncs radiate them and then do short interval brain MRI to see if it's going to be uncontrolled and really active brain disease or if it's going to calm down.
Yeah, the same, especially after Destiny Breast 12. I think that's
Mhm.
an active agent. And just on inpatient service, it's not an uncommon scenario. And often these patients get admitted, and the question becomes, what to do. I think for HER2 positive disease, given the newer agents we have, it's certainly reasonable to consider a systemic agent.
And do you find that there's, that obviously neither of these um, regimens have been compared to one another, but do you find one to be more compelling than the other? I think initially there was data with tucatinib that
That's the trial. Thank you. Yeah, Demether. Yeah, I knew it was a funny name. Um, so one of the things I think that Aditya is referencing is that while we're not supposed to do cross-trial comparisons, we all do. And the data for Destiny Breast 12, which was in HER2 for brain metastases and a good proportion of untreated brain metastases. That was better as far as progression-free survival and overall response rate than any other CNS trial ever done in breast cancer. So that is officially sort of the most active agent in the CNS that we know of right now. So people think, oh, they've got brain mets. This was sort of the old dogma before we knew the Destiny Breast 12 from ESMO. Oh, they should be on a TKI because that passes the blood-brain barrier better. They should be on tucatinib, Xeloda, and trastuzumab. But the Destiny Breast 12 trial actually had better overall response rates and progression-free survival than the HER2 Climb regimen, like pretty significantly.
so I mean do we know that so it must cross the blood-brain barrier? I mean, was there initially some concern that it may not be effective in crossing the blood-brain barrier, or we know that it does? I know that we know that tucatinib is a small molecule inhibitor, whereas ADCs uh, are we do we know its mechanism of action? Do we know the amount of drug that may get into the CNS?
So two things is one, these brain metastases make the blood-brain barrier leakier so that we do have better penetration just by nature of having the brain metastases or leptomeningeal disease. But also what we're seeing within HER2 when we're doing longer follow-up and piecing this together is that there is a significant amount of free drug just kind of floating around than we thought. We thought that the linker was a little bit more stable and needed to be hydrolyzed and whatnot, but what we're seeing is a lot of the effects of this drug are from free topoisomerase 1 inhibitor. And so there's a good amount of that that gets into the brain. But yes, it's certainly different than TDM1, where we don't see good response into the brain. That's not a good agent for brain disease and should never be really considered an active agent in that line. T-DXd seems to be totally different. And same with sacituzumab govitecan. They both have really good intracranial response rates.
We have a question in the chat room, and that is from one of our attendees here, and that is how important is capecitabine when combined with tucatinib and trastuzumab? Um, obviously the trial and the regimen of tucatinib was approved in combination with trastuzumab capecitabine. But if do you feel that that could be potentially omitted from a regimen? Is there some activity with tucatinib by itself or with trastuzumab, just the two of them?
There's certainly some activity of the two of them, and in a patient with significant comorbidities or tolerance issues, I have definitely done that without the capecitabine before. I wouldn't necessarily go about just trying to omit it up front. Sometimes I'll drop it based on tolerance. If the patient's really stable, I'll just continue the tucatinib and then trastuzumab alone. But we know that capecitabine has pretty good blood-brain barrier penetration. And as far as CNS goes, it does penetrate quite well. You have to get to a little bit higher doses, and that's tough as far as hand-foot syndrome. But while the triplicate therapy is ideal in patients who have difficult time to tolerate, I will either dramatically dose reduce the capecitabine or omit it.
Oh, thank you. Um, Anything else emerging in the HER2 setting that you're excited about? I know that our HER2 positive patients now are living much longer. Aside from moving up these regimens into the earlier lines, are there other molecules that you're excited about?
Um, I know that I'm fairly excited about the drug zanidatamab, which is a bispecific. It has had really promising results in one and two trials. We've used it in the I-SPY2 trial in the curative setting. And so that it has been fast tracked, and I think I'm really looking forward to that one.
What's its target in the bispecific realm? Do you know offhand?
Um, it is, yes, hold on one second. Aditya, is it HER2 and HER3?
Yeah, so essentially it's like pertuzumab and trastuzumab
That's it.
combined
Yeah.
into one. So one component binds to domain 2, one to domain 4. So it's like giving HP, and as Becky was saying, shown quite good results, and there's a phase 3 trial ongoing. So in terms of agents, yeah, I agree, that's the one I'm excited about.
Excellent. Okay, well, and that's being evaluated in the adjuvant setting you mentioned?
Not quite in the adjuvant yet. We've actually in the I-SPY2 trial, which is a very, very large national
That's in the
neoadjuvant
neoadjuvant
trial.
setting.
Yeah, so we've used it in the neoadjuvant setting. We haven't reported out results, but that arm has been ongoing for a while, and anecdotally, we've seen very good results.
All right, excellent. Uh, Christy, can we go to slide 19 on triple negative breast cancer? And we're going to start the last case. Okay. Okay, so
Sorry,
this, yeah,
Sherry. I
yeah,
can't see numbers on here, so
you
just
can
tell me
just keep going.
keep going.
I'll tell you
Okay.
when to stop. Yeah, keep going. Yeah, go ahead. Yep, right here. No, go back one.
Okay.
Okay, great. Thank you. All right, so we'll kind of wrap up with our last case, and this is a triple negative breast cancer. It's a young woman presented with a large 6.5 centimeter left upper outer breast mass with palpable adenopathy, found to have metastases to the lung and bone. Biopsy of the lung and bone, as well as the lung and bone were done, and consistent with triple negative disease, PD-L1 was 0. Tissue NGS showed a number of mutations, none of which were considered actionable. Germline genetic testing was negative. So their PD-L1 level was 0. So in a patient like this, Dr. Bardia, how would you approach this patient, and what would your thoughts be in terms of frontline and possible second, third line treatments?
Yeah. So in general, for triple negative breast cancer, we look for three biomarkers. The first one is germline BRCA because that's actionable. Second one is PD-L1, that's actionable. And third these days, HER2 to see if a patient has HER2-low disease. So if the tumor is PD-L1 positive, in general, I would consider chemotherapy plus immunotherapy. If the tumor is PD-L1 positive and patient has germline BRCA mutation, I will still consider immunotherapy plus chemo first line and then reserve PARP inhibitor for second line and beyond. And if all of this is negative at this time, we would use chemotherapy, platinum generally, although you can use a taxane in the first line setting, but that's going to change. We saw a press release related to the ASCENT-04 trial, which looked at sacituzumab govitecan plus pembro versus chemo pembro for PD-L1 positive metastatic TNBC first line. And as per press release, is a positive study. Another potential practice changing study being presented at ASCO. So the landscape is likely going to change and ADCs will move in the first line setting.
And in conjunction with immunotherapy. And is that independent of any biomarker, or was that a biomarker driven study?
It was independent, so just metastatic TNBC, PD-L1 positive. So in that setting, SG plus pembro versus chemo plus pembro. There's a separate study looking at ADC versus chemo for tumors that are PD-L1 negative.
Yeah. So let me ask you, if a patient like this presented, would you if the patient had somewhat extensive disease, or not, for example, I mean, would you approach with a platinum doublet? Would you do single agent therapy initially?
Yeah, I've seen it be different depending on the region you are in. There are some who swear by platinum plus gemcitabine, and there are others who say that all gemcitabine does is increase risk of thrombocytopenia, and they just use platinum alone. Many trials have used platinum plus gemcitabine, so it's certainly not wrong. I personally tend to use single agent platinum.
Okay, yeah, Dr. Shatsky, any differences in how you might approach this patient?
Sometime in a de novo metastatic, they are quite sensitive, and I will use Abraxane to start. And, that's sort of extrapolating that some of the studies that used Abraxane versus paclitaxel had maybe a little bit higher response rate. But, if I was going to go with the platinum, I tend to do every 3 week carbo, or carbo gem. I don't do a lot of the day 1, day 8 necessarily because it seems unnecessary. It ties them to the infusion center more and makes them use growth factor even more. But yeah, carbo gem or Abraxane would probably, in someone who's got a large burden of disease and I can't get access to sacituzumab, I'll do carbotaxol. Works quite well.
And then what about in these patients who are HER2, negative, any role for T-DXd in these patients?
So right now the approval sort of excludes it because the HER2 ultra low study that for Destiny Breast 06 was hormone positive. So it would be difficult to get that through insurance. That's not saying I haven't tried, but usually if I was going to go on after an ADC in that situation, I would try to make an argument for sacituzumab.
Yeah. Yeah, this patient was treated initially by me. I did initiate her on carbo gem. I did drop the gem after a few cycles because of
The platelets.
the the cytopenias. Even with dose reduction of gem, it was very difficult. And then she received sacituzumab govitecan, did well for a bit, and then cycled through a couple of additional um, uh, treatments, single agent chemotherapies. But by and large, it was very unfortunate, and not terribly satisfying as this disease can be. Any novel agents in this realm that are being looked at? I know that there has been some looking at some interest in looking at androgen receptor inhibitors in triple negative disease. I don't know if that's something that might be close to prime time.
So androgen receptor antagonists and inhibitors are helpful somewhat in the rare subtype of triple negative breast cancer, the luminal androgen receptor positive disease. And that's maybe about 10% of triple negative breast cancers at most. And so the typical, like this young patient with aggressive de novo disease is not something that I would think about. Those studies, a lot of them were done by one of our colleagues, Bora Lim, who's at MD Anderson now. They mostly showed stable disease as opposed to like some significant benefit. And that type of triple negative breast cancer tends to act more like a hormone positive and sort of have a more indolent fashion than not necessarily going straight for the liver or the brain like aggressive triple negative does. As far as new agents, I am excited about newer antibody drug conjugates that have different payloads. So some of them have MMAE. There's one that I haven't heard much progress for lately, but it was called like BB1707. It had an eribulin payload. And then there is the BioNTech molecule, which is a bispecific that is, I think, an immune checkpoint plus VEGF inhibitor. We know that some of the more refractory TNBC does overexpress two things. One is EGFR, and the other is VEGF. And so I, in very highly refractory disease, will reach for things like bevacizumab and lenvatinib if I need to for now, but I'm hoping that better agents, will come out to target those.
Yeah. Dr. Bardia, any final thoughts on triple negative disease that you want to
Yeah, we've
mention?
made some progress, but I think a lot more needs to be done. So a lot of interest in additional therapies, newer payloads, newer ADCs. As Becky mentioned, this in lung cancer, we've seen good results with this dual PD plus VEGF inhibitor. So maybe in breast cancer, we'll also see good results. So we definitely need to do more. And then maybe from a genomic level, try to understand this disease better and see if there's a subset. Can we further classify TNBC into something actionable and have targeted therapy for that subgroup of TNBC? We've
Yeah.
tried for a while, a lot of genomic results, but nothing has panned out yet, but doesn't mean that we should stop trying.
Yeah, and this case is interesting. So I sequence every single TNBC always, and these are quite rare mutations. I've never seen the LZTR1 before, and I see a lot of Notch1 in apocrine TNBC, but Notch3 is fairly rare as well. So these are almost all TNBC has a TP53 mutation. If not one, they have many. But these other sort of mutations are on the rarer side.
And would you, any role in repeating NGS testing either by liquid or tissue biopsy? And
I certainly do it. I have had success before and come up with strange things. Like I had a really horrible metaplastic TNBC that on ctDNA on progression one time had a FGFR fusion, and I actually targeted that with a pemigatinib and had a really fantastic response. That's a toxic drug. It really has horrible eye toxicity and hyperphosphatemia and skin tox, but it had a fantastic response. It was an inflammatory TNBC, just sort of like barreling through everything. I've had other driver mutations for sure. I've had BRAF V600E that I've successfully treated with BRAF and MEK inhibitors. So I always look. You never know.
I think that's the point, and that's what we need to kind of continue to remind ourselves. Well, on that note, I want to thank both Dr. Shatsky and Dr. Bardia for being here with us and reviewing these cases. Obviously, I think ASCO 2025 is going to be exciting with some perhaps practice-changing regimens being presented. So we should learn more in the next month or two. So thank you to everyone who helped put this together. And Dr. Shatsky, Dr. Bardia, thank you so much.
Thank you.
Yeah,
Thank
thanks
you,
for
guys.
inviting us. It's
Yeah.
really fun.
Good evening, everyone. Good night. Bye-bye.
Thank you.